Hello, we are Group Pacific Standard Time Mountain Time, and in our presentation, we will be covering the effects of video self-evaluation on skill acquisition with yoga poses. Our group consisted of
Randy Benefield,
Jessica Chan,
Jessica Chandran,
Michael Hawkins,
and myself, Adriana Medina. Next slide. The articles in our literature review are a combination of articles that were cited within our original study to support the research topic, as well as from other studies that focused on yoga or the role of behavioral interventions in the world of athletic performance, as well as for teaching complex skills. The first article is Diamond 2012. This article dives into the evidence in support of prescribing yoga to patients in primary care as a method of stress management. According to the author's research, approximately 75 to 90% of visits to primary care services are related to stress, which is often a result of the patient's lifestyle. The author cites various studies that have found yoga to have anti-inflammatory effects on the endocrine system, as well as a positive effect on the immune system. Diamond concludes that existing research offers convincing evidence of yoga's multiple health benefits, particularly in regards to stress management. The second study is a pretty recent study and was co-authored by Raymond Miltenberger. He was one of the authors of the original study that we chose to replicate. He has contributed a lot in terms of research and work in the world of ABA and is probably best known for his work on developing what we now know as behavioral skills training. This study utilized a multiple baseline design across participants to evaluate the improvement of a complex ballet movement called a brisé for 4 female dance students ages 9 to 13 years old. The procedure involved the implementation of video modeling alone, followed by a video modeling plus video feedback condition. The results of the study showed that video modeling alone produced only modest increases in dancer performance of the brisé movement, while video modeling in combination with video feedback produced much greater increases in performance. Shent and Miltenberger's 2019 review of behavioral interventions to enhance sports performance identified 101 studies published since the late 60s that focus on using behavioral interventions to enhance athletic skills and performance. The most frequently used interventions included video feedback, self-monitoring, antecedent procedures, positive and negative reinforcement, auditory feedback, instruction, and goal setting. Schonwetter, Miltenberger, and Oliver's 2014 study evaluated self-monitoring to improve swimming performance. The results demonstrated that descriptive verbal feedback helped enhance lap swimming performance when other interventions failed to produce substantial effects. And lastly, Yu and Lee's 2010 study was a study conducted in Korea in which they analyzed the effects of video self-evaluation on nursing students' catheterization skills. This study was included in the literature review because, similarly to our original study we replicated, it involves the use of video self-evaluation. Results of the study showed significant differences between the control and experimental groups, indicating that more steps of the catheterization process were retained by the group who self-evaluated their own video performances. Next slide.
the original study, Downs, Miltenberger, Podronsky, and Witherspoon in 2015 was a study on the effects of video self-evaluation on the skill acquisition with yoga postures. The purpose was to evaluate the effectiveness of 2 interventions using the video self-evaluation and the video feedback in regards to the accuracy of each participant's yoga pose. The participants were just 2 university students, ages 21 and 24. The study was in a fitness lab on the university campus. It used a multiple baseline design across the behaviors. They used 3 beginning common yoga poses, and the study was used video self-evaluation and video feedback. Next slide, please. So our replication study included 5 participants, 2 males, 3 females, varying ages. Randy is 55, Jessica Chan, 29, Jessica Chandran, 27, Michael, 26, and Adriana, 31. All participants are currently enrolled at Ball State University. Participants had some experience in yoga and did not have any current injuries. The participants lived in various areas of the United States, so the study was conducted in each participant's home. All participants were interested in knowing if this could replicate this study by improving their yoga poses using video self-evaluation. It was requested by our team that participants not practice yoga outside of the experimental sessions. Materials. Participants use laptops, tablets, or iPads to record their performance. These were also used as a medium to meet via WebEx for researchers to implement sessions 1 and 2 with their participants. Yoga mats were used by the participants. A task analyses were used to score whether the participants performed each step of the 3 yoga poses correctly or incorrectly. A treatment fidelity checklist was also used to track the treatment integrity. Google Sheets were utilized to record researchers and the participants' data. And then we used a timer to track the duration of each pose held. Next slide.
Our group selected 3 poses that were practiced in an intermediate yoga pose. The first pose was Ardha Pincha Murasana, or dolphin, which is defined as a pose in which the balls of the feet are pressed into the mat with the body bent downwards at the hip, and both elbows and forearms are touching the floor with interlocked fingers of the hands. The body should form a triangle with hips in the air, straight legs and back, and the head is held down between the arms with the gaze directed towards the floor, towards the feet. Pose should be held for 30 seconds before slowly releasing. Non-examples include holding the pose with a bend in the knees or the head resting on the floor. The second pose is Ardha Mukha Shavasana, or upward facing dog, which is defined as a pose in which the head is facing upward while hips and thighs are lowered toward the mat without making contact. The only parts of the body touching the floor are the palms of hands and the tops of the feet with arms straightened. The pose is held for 30 seconds and then slowly released. Non-examples are when one is getting down to the floor, getting up from the floor, or resting on the floor. The third pose is the Virabhadrasana 3, or the Warrior 3, which is defined as a pose in which the right foot is placed flat in the middle of a yoga mat with a straight leg, while the left leg is extended straight back at a 90-degree angle to the right leg with toes pointed towards the wall. The person's torso is bent forward and the chest is parallel with the floor. Both arms are stretched forward with splayed fingers and the palms are facing one another. Arms are parallel with the floor. A figure T is formed with the 2 arms and 1 leg forming the top part of the T and the right leg forming the perpendicular line of the T. Non-examples include reaching both arms forward without lifting 1 leg off of the ground and posing with any knee or elbow bent at an angle. Next slide, please.
So participants recorded their yoga poses using a webcam or a laptop. A webcam from their laptop or a tablet, sorry. A timer was used to document whether the pose was held for 30 seconds or not. And we used 3 different task analyses to score each respective pose, as you see here. Each one is the dolphin pose, upward facing dog pose, and Warrior 3, respectively. Correct steps were scored with a plus and incorrect ones were scored with a minus. For example, if in Warrior 3 pose, you held the pose for 30 seconds or longer, that would be considered a plus. But if you held it for 29 seconds or anything less, that would be considered a minus. To get our percentage of correct steps, we would calculate the amount of correct steps divided by the total number of steps and then multiply that by 100. For the first 2 intervention phases, both the participant and researcher were present, and the researcher would explain to the participant how to accurately score their poses, and this was to ensure proper data collection and strong inter-observer agreement. So this was done by the researcher explaining why each step received the score that it got. And in the second session, the participants scored their pose independently, and the researcher scored it as well. And then they compared their scores, and the researcher would explain any discrepancies in scoring, and if need be, explain how to do that step correctly. Next slide, please.
So the design we used was a multiple baseline design across behaviors, which was similar to the original study. This design was used to record the baseline and intervention phases for all 3 yoga poses for each participant. Next slide. For our phases, our baseline session, for the first 2 sessions of the baseline phase, the participant viewed a YouTube video by Ventuno Yoga on each pose and then recorded themselves performing the pose. Each pose was only attempted 1 time. Following the first 2 sessions, the participant continued performing the yoga poses without watching the instructional videos. Each participant uploaded their videos to a Google Drive folder where their assigned researcher had access to view the videos in order to score them using the task analysis. Next slide. For our treatment phase, once the researcher evaluated the poses for a minimum of 5 baseline sessions, they selected a pose to go into intervention based on which pose showed the most stable data. After recording the first intervention session for each pose, the participant met with their assigned researcher via WebEx to discuss how to score the task analysis. During the meeting, the researcher and participant reviewed the video together while the researcher modeled how to score the task analysis correctly. They provided feedback for each step on the task analysis, specifically how to correct those that the researcher scored as incorrect. For the second intervention session, both researcher and participant once again reviewed the video via WebEx. This time, the participant was expected to score themselves while the researcher provided feedback. For the following intervention sessions, the participant used the task analysis to self-evaluate their videos. We also had video feedback. So throughout the study, the participant uploaded their scores for each session to a shared Google Sheet so the researcher could monitor the participant's progress. If the data did not show improvement or it showed a decreasing trend, then a video feedback phase would be implemented. The researcher would provide feedback and reteach the participant how to use the task analysis. Next slide.
IOA data. So all members played a role in calculating the IOA data. During the intervention, the participant took task analysis data while the researcher reviewed 33% of the participants' sessions to calculate and determine the IOA. Each member also assumed the role of the observer and was randomly assigned to a different participant. Their job was to review and take IOA data for 33% of the baseline. IOA was calculated by dividing the number of agreements, odd steps in the task analysis, by the number of total steps, and then it was multiplied by 100 and to attain a percentage. An agreement occurred when both scorers marked a step as correct or incorrect. During baseline, an additional group member was assigned at random to assume the role as an observer in order to collect IOA data on the researcher. During intervention, the researcher would collect IOA data on the participant's self-evaluation data. For participant Randy, his IOA data ranged from 57% to 100% with a mean of 78% in baseline and a mean of 81% in intervention. For Jessica Chan, the IOA data ranged from 57 to 100% with a mean of 82% in baseline and 91 in intervention. And for participant Jessica Chandran, IOA data ranged from 71 to 100% with a mean of 87% in the baseline and 93% in intervention. And for participant Michael, his IOA data ranged from 57% to 100% with a mean of 77% in baseline and 85% in intervention. And for Adriana, her IOA data ranged from 64% to 100% with a mean of 86% in baseline and 88% in intervention. Next slide, please.
Treatment integrity. Our group created a treatment fidelity checklist to assess treatment integrity. The researchers collected treatment integrity data on 33% of their participants' sessions, and data was collected or calculated, using the following equation. The number of correctly implemented steps by the participant divided by the total number of steps on the treatment fidelity checklist multiplied by 100. Participants Randy, Jessica Chan, and Michael attained 100% treatment fidelity, while participant Jessica Chandran ranged from 90 to 100% with a mean of 92%, and participant Adriana ranged from 89 to 100% with a mean of 93%. Next slide, please.
So taking a look at my data, the first pose, yoga pose, that went into intervention was the upward facing dog. And if you see here, my first average was 29% in baseline, a range of 14% to 43%. And then self-evaluation, the average was 63% with a range of 57 to 86%. Now, you look at my dolphin pose graph, and you have a dot that went into intervention. So I only had one session for that due to an illness. So therefore, I did not take any or calculate any average or range for self-evaluation. But on the dolphin baseline, I had a 46% average, a range of 20 to 70%. And the warrior pose never went into intervention. It stayed in baseline, average of 35% with a range of 0% to 64%. Next slide, please.
This is my data. As you can see, the pose upward facing dog was the first to go into intervention at session number 6. Baseline mean was 60% with a range of 43 to 71%. My intervention mean was 97%, which showed a 37% increase from baseline phase. My intervention ranged from 86 to 100%. Warrior 3 pose was my next to go into intervention at session number 9. The baseline mean was 54% with a range of 27 to 64%. The mean increased by 28% to a total of 82% for my intervention mean and a range of 64 to 91%. My dolphin pose baseline mean was 87% with a range of 40 to 100%. And because of the behavior's rapidly increasing trend, my researcher decided not to implement intervention on this pose. Next slide, please.
This is my data. So Warrior 3 was the first of my poses to go into intervention. So I started with a baseline average of 66% and a range of 55 to 82%. For self-evaluation, I had an average of 81% and a range of 45 to 100%. My second pose to go into an intervention phase was upward facing dog with a baseline average of 74% and a range from 57 to 100%. In self-evaluation, I increased to an average of 91% with a range of 71 to 100%. My dolphin pose, as you can see, did not lead into intervention. My baseline average was 97% and a range of 80 to 100%. And my researcher decided to not have this phase go into intervention due to the very stable data that it was showing. Next slide.
For my data, I went into self-evaluation for only the Warrior 3 pose. In baseline, my average was 29.1% with a range of 18.2 to 45.5%, which increased to an average of 67% with a range of 45.5 to 81.8%. And as you see in my upward facing dog pose, I did not go into self-evaluation, with that average being 74.7% and the range for it being 42.9 to 100%. And for the dolphin pose, I had an average of 90% with a range of 60 to 100%. And as you see in the last few sessions, my data was very steady, which stopped us from going into self-evaluation for that. Next slide, please.
So here are my graphs. As you can see, Warrior 3 was my first and only pose to go into intervention. For that pose, my average during baseline was 49.2 with a range of 27 to 73%. Even though my data was pretty variable in baseline for that specific pose, as you can see from dolphin and upward facing dog, my baseline data averages for those were around 91%. So my researcher determined that it would be more appropriate to implement an intervention for Warrior 3 where my levels were pretty low. So with Warrior 3, my average went up to 80.6% with a range of 45 to 100%, with the last two data points being 100. And as you can see from my dolphin pose, I had 6 sessions at 100% and some deviation from that with upward facing dog, but still at around that 100 level. Next slide, please.
Some of the limitations that our group encountered were the fact that we resided in different locations and time zones. So that meant we relied heavily on video conferencing. This was seen as a disadvantage because modeling a pose or the steps leading up to the ending pose would have been much easier in person, since that would have allowed researchers to physically redirect their participants if necessary, versus a verbal redirection that could be easily misinterpreted. We also had a lot of issues with internet connectivity throughout our whole study. Another limitation was the pre-existing conditions and illnesses the group had. For example, one group member had undergone ACL surgery on her right knee, so she found Warrior 3 pose extremely difficult to perform since it required balancing her weight solely on her right leg. Another member had reoccurring back problems, so they found it difficult to perform the upward facing dog pose since it required them to bend their body backwards. At one point, everyone in our group was sick, so the effects associated with being sick, like fatigue or headaches, may have influenced our motivation and overall participation. COVID-19 also had an effect on our study. And even though yoga could be practiced anywhere, the effects of COVID-19 caused members of the group to experience an increase in demands from their daily life. For example, school closures. School closures for a member who worked at a high school meant she had to redirect all her attention to restructuring the curriculum in order to accommodate virtual learning for her students, while another member experienced more parental demands regarding the services she provided for her child. Another constraint was the restrictions our professor placed on our project. So although the original study involved certified yoga instructors, we couldn't seek any help from anyone outside our group, so that meant we couldn't employ any professionals to show us or demonstrate the correct steps for each of our chosen yoga pose. So instead, we had to resort to YouTube videos from the Ventuna Yoga channel. And because we weren't allowed to show any outsiders our recordings, we don't really know how accurate or correct our yoga poses are, especially since none of us are certified yoga instructors. They also use certified yoga instructors to assess the social validity of the task analyses and the quality of the poses. But once again, we couldn't replicate this aspect exactly due to the project restriction So we assess social validity through verbal expressions during our group meetings. The most impactful limitation we had was the biases we encountered due to the project restrictions. So although in the original study, the participants were blind to the intervention during the baseline phase, they didn't have access to the task analyses the researchers used to score their behaviors. However, in our replication study, each group member had to assume the roles of participant, researcher, and observer. So that meant a group member could gain access to the task analyses when they became the researcher in order to evaluate their assigned participant. So the ability to view the list of steps for each yoga pose could have influenced our performance during baseline. So that meant this constant reminder may have increased our performance, especially since the participants were expected to perform poses based off memory. Next slide.
So due to the outcome of our study, our results suggest that video self-evaluation is effective in increasing our proficiency in performing our 3 yoga skills. And these results also suggest that video self-evaluation and video feedback can be used to improve the form of various physical tasks independent of a professional trainer, as long as they've received sufficient initial performance training beforehand. In the future, this study should not be run as both researcher and participant, and that is because that made the factors of the study a lot more complex and confusing in terms of who would oversee whose data, and it took up more time than it really needed to. But that has been our presentation on the effects of video self-evaluation on skill acquisition with yoga poses. Thank you for listening.
Here are our references. Thank you.